So today's topic is dislocation of the shoulder. Yeah, the shoulder instability basically is a jinx. So it has got so many varieties in it. The instability patterns are many, and the management strategies are further getting more and more evolved. So speaking of an introductory part of it, the shoulder anatomy and its biomechanics. Shoulder is a ball and socket joint, and it has got maximum mobility at the cost of dicey stability. So it all comes at a cost. So the mobility is very high, but the stability is definitely compromised, and the glenoid covers only 25 to 30% of the humeral head, and this leads to a limited intrinsic bony stability. So the surrounding soft tissue is very important for the stability of the shoulder joint. Speaking of the stabilizers, there are static stabilizers and dynamic stabilizers. So bony anatomy itself is a static stabilizer wherein the glenoid faces upwards, even though it's less congruous to the humeral head, but still the direction is one of the component of static stabilizer. The glenoidal labrum, the negative intra-articular pressure, the capsuloligamentus structure and the rotator cuff muscles are other static stabilizers. Among all these, the capsuloligamentus structures are the most important static stabilizers. Among the dynamic stabilizers, we have got rotator cuff muscles, the long head of biceps tendon, the deltoid, the scapular motion and the proprioception. So these form the components of dynamic stabilizers. Both have to act in unison to give stability as well as movement to the joint. This picture may look a lot cluttered, but this is the portion we have to concentrate on, the rectangle drawn here. So this is the anterior portion of the joint, wherein we are seeing the anterior end of the glenoid. We are seeing the layers of the soft tissue or the capsulolabral structures here, wherein the periosteum, the labrum, the synovium and the anterior capsule along with the tendon of the subscapular is going all the way to the lesser tuberosity. These form the anterior layer of protection against a dislocation. As well as you can see here the biceps tendon and the intertubercular ligament. So this is the greater tuberosity, this is the lesser tuberosity here. The capsule in the shoulder joint, I have to mention a point. The capsule, unlike other joints, it's not very tight, it's quite redundant. It's little lax to allow for the mobility, but only at the extremes of movement, the end range of movements, that is when the capsule becomes tight. So in case of injuries to the capsule, it is only during the end range of movement the instability is triggered. So during the mid range of mobility, wherein patient is doing an abduction of about 90 degrees, there is no apprehension. But when the patient goes overhead and then externally rotates, that is when there is apprehension. So the anterior structures, the capsule itself becomes tight in terminal motion, in the end range of movement. That is when in case of injury, the chances of dislocation are very high. So this is one more sagittal image wherein we can see the glenoid and the surrounding soft tissue. This is the anterior portion, this is the posterior portion. There are a few important structures I just want to highlight on. The three ligaments on the anterior and the inferior side, the superior glenohumeral ligament, the middle glenohumeral ligament and the inferior glenohumeral ligament complex. Inferior glenohumeral ligament complex has got three parts: the anterior band, the axillary pouch as well as the posterior band. So these together are very important for giving a good support on the inferior and the anterior side to the humeral head. So the stabilizers basically, in the end range of movement, as I mentioned, it's the capsuloligamentus structures which provide stability. These are very important to be intact for avoiding dislocation. And in the mid range, it's the negative intracapsular pressure as well as the concavity compression effect, and obviously the static stabilizers. Speaking of the incidence, the glenohumeral dislocation is the most common dislocation of all joints, ranging as high as 45%. I'm sorry. Then the anterior dislocation is the most common one, which is 90%, followed by posterior, inferior or multidirectional in another 10%. So the peak incidence is 20 to 29 years old. So it is very common in young, very active male patients, and most commonly traumatic. The second set of patients are the elderly, wherein 80 to 89 years old patients, they have got associated fractures. So it has got a bimodal pattern, wherein the younger patients present with traumatic dislocation, and the elderly, they present with very trivial trauma associated with fractures. The chances of recurrent dislocation are very high in younger males. So the first set of patients who are ranging between 20 to 30 years old have a dislocation rate on the second time or the third time as high as 30%. I just want to emphasize one point here. Laxity is not same as instability. One point we have to understand is some joints may be really lax, but the patients may be asymptomatic. Instability is invariably symptomatic. Patients have got apprehension and associated pain in some cases. So we should never consider laxity and instability as synonymous. Just to speak on the definitions of dislocation and subluxation. Dislocation is a complete symptomatic dissociation without spontaneous reduction. When you are not able to reduce by self, when it is confirmed on a radiograph, that is when we call it a dislocation. Whereas subluxation, it is symptomatic dissociation with spontaneous reduction. Most of the patients, when they are able to reduce by themselves, most of the times it's spontaneous reduction, it's subluxation. So apprehension is a quality of both dislocation and subluxation. So apprehension is like a hallmark feature of these entities. But without apprehension, you should think of other diagnoses. So etiology basically is classified into traumatic, atraumatic, microtraumatic and neuromuscular. Traumatic being the most common one and neuromuscular being the least common one. So the classification is basically a descriptive classification which is classified into multiple portions. You can classify it based on severity, based on etiology, based on chronicity, based on frequency, based on volition, based on direction. So the classifications are multiple. There is no single classification wherein you can put a patient. A patient may have a traumatic anterior dislocation which was the initial time or the recurrent time. So that's how we classify it. So traumatic anterior recurrent dislocation. So we'll have to put all the points into the diagnosis. So the diagnosis is never under a single umbrella. It's basically the multiple points which will have to come into the diagnosis. So just the common types of dislocation that we can encounter are traumatic anterior dislocation, which is the most common variety, followed by recurrent anterior subluxation. These are set of patients who have an episode of acute traumatic dislocation in the past, now having multiple times subluxation. Then acute and chronic traumatic posterior dislocation. So these posterior dislocations are notorious and can be missed. Most of them are acute, 50% of them go undiagnosed and most of them get converted to chronic. So these acute and chronic traumatic posterior dislocations are notorious. Then recurrent posterior subluxation. So posterior subluxations are rare, but these can be acquired, volitional wherein it's voluntary, then dysplastic. Dysplastic wherein there is anatomical variations in the glenoid as well as humeral head. Then there is multidirectional instability. This is very common and most of the times is associated with subluxation rather than complete dislocation. So what's the mechanism of injury? So the mechanism of injury is basically in anterior stability is an indirect mechanism. Very rarely there is a direct blow on the shoulder. It's basically an overhead, during an overhead sport like smashing a ball, in abduction and extreme external rotation, that is when the shoulder gets dislocated anteriorly. In posterior instability, this occurs most commonly in elderly patients associated with fractures. This is also an indirect mechanism. Rather than a direct blow on the shoulder, it is the flexion, adduction and internal rotation with an axial load. Basically, it's fall on an outstretched hand. This time the patient can have a distal radius fracture or can have a anterior dislocation or a posterior dislocation. So the clinical diagnosis, it's a telltale picture. Most of us would have seen this picture, this kind of patients in our emergency wards, wherein the patient is holding their forearm and drooping the shoulder. So the moment we see the prominent acromion, loss of the deltoid contour, and the axillary folds are distorted, and the patient is in extreme pain, not able to touch the opposite shoulder, all these features suggest that it's an anterior dislocation. So what we can miss in emergencies, what we can miss during our work in the OPDs or in the emergencies is posterior dislocation, as high as 50%. These go for chronic neglected dislocation, and reduction and stabilization can be really a trouble. So 70% of these posterior dislocations can be traumatic and 30% can be due to electric shock or epilepsy, and these are very difficult to manage. So the anterior dislocation, most common variety is a subcoracoid type and reduction is relatively easy. Then there is a subglenoid variety which is mostly associated with a GT fracture. Then there is inferior dislocation or luxatio erecta, which is relatively uncommon, wherein the patient presents to us with the whole arm and forearm raised overhead, not able to adduct it. So what are the tests for anterior instability? So I will be focusing mainly on anterior instability, which is a very common topic and most of the times asked in many exams, as well as the number of patients we see are relatively very high. So this is the apprehension test, wherein we abduct the shoulder to 90 degrees and externally rotate. That is when the patient has got an apprehension that the joint is going to pop out. So this is the hallmark test for anterior instability. Then there is a fulcrum test, wherein in the same position as apprehension, when you pressurize from the posterior side, the patient has got a feeling of popping out of the shoulder, wherein the pain and the apprehension gets exaggerated. Then there is a relocation test. In the same position, if we pressurize from the anterior side, the joint tries to get relocated and there is a relief. The pain or the apprehension comes down. Then the crank test is in sitting position, wherein abduction and external rotation, the humeral head is being pushed anteriorly, wherein there is an apprehension. The test for posterior instability is basically a jerk test, wherein 90 degrees of forward flexion and internal rotation, we just try to jerk the shoulder posteriorly where there is an apprehension. So the non-operative management in acute anterior dislocations, it's most commonly done in first time acute dislocation. That's what we see in our emergency wards. Then there is a recurrent instability without prior treatment, recurrent traumatic instability, then chronic dislocation with good function and no pain. Then a patient medically unstable and unstable epilepsy. So these last conditions are wherein we operate, the results are relatively poor. So they are basically skillfully neglected. Then the close reduction of anterior dislocation has to be ideally done in an operation theatre under sedation, and a C-arm image or the radiography should always be taken, and patient positioning and immobilizing the arm are very important. So this is how all of it started. So we can see the Hippocratic era, wherein two people are basically pulling the shoulder to reduce it, and that was a very native stage of medicine, and eventually it got evolved, wherein we do close reduction by traction counter traction method. This is one method which is done in most institutes. Then there is Stimson method, which is seldom done, wherein the patient is prone and weight is hanged from the wrist. Then there is gentle controlled external rotation, reduction and internal rotation. So this maneuver most of the times works and can be done without local anesthesia by counseling the patient about the procedure. Getting a post-operative post-reduction check radiograph is of utmost importance. Then speaking of the operative indications, an anterior instability, irreducible, unstable, first time acute dislocation, when you reduce as well as later you see that it's getting dislocated again, especially with associated fractures. That is where we'll have to intervene by surgery. Then the recurrent instability, wherein the rehabilitation has not worked, then open injuries and chronic dislocation with poor function and dislocation associated with proximal humerus fractures. And the contraindications are patients with epilepsy, first time acute dislocation, recurrent instability without prior treatment, and patient medically unstable. The two most important deciding factors and the points we should know are the anterior glenoid bone loss as well as the Hill-Sachs lesion. So based on the bone loss in the glenoid as well as the bone loss in the humeral head, which is called Hill-Sachs, we just go ahead whether to operate surgically. When we evaluate the patient, the series of investigations we do are radiographs, MRIs and CT scans. I'll just briefly speak on them. The most elaborative is in acute dislocations. That is when we take X-rays and we come to know that it's an anterior dislocation. We can't miss an anterior dislocation on the radiographs. Posterior dislocations are definitely missed sometimes. So that's the reason why we take axial views. Then the radiographs can describe about the associated fractures. The GT fractures as well as the fractures in the proximal humerus can be seen on the radiographs. But radiographs are not penultimate. We'll definitely need to further evaluate, especially in chronic, neglected and recurrent dislocations. Then we go ahead with the MRI. MRI describes in detail about the capsulolabral injuries and rotator cuff injuries. So this is very important in surgical decision, but still it's not complete. This is important recurrent dislocations, but it's still not complete without a CT scan. So CT scan becomes very, very important to evaluate for the bone loss, and the percentage of the bone loss and in the glenoid as well as in the humeral head, that paves a path to decide about further surgical management, whether we go ahead with surgeries like Bankart repair alone or Latarjet procedure or arthroplasty. So we all have heard about these terminologies now. Bankart, wherein the anterior glenoid is involved, Hill-Sachs, wherein the posterolateral part of the head of humerus is involved. We see the Bankart lesion here anteriorly in the glenoid side. It can be a bony Bankart or a soft tissue Bankart. Then we have seen Hill-Sachs on the posterolateral aspect here, wherein it's getting engaged here on the glenoid during the dislocation. But have you heard of a term called bipolar? Bipolar is not just in psychiatry, it's also in orthopedics. So 4 out of 5 patients with anterior instability have both glenoid lesion as well as humeral head lesion. So we have to understand that the involvement of the anterior glenoid as well as the Hill-Sachs on the humeral side decides the management protocol. So the glenoid loss can be of fragment type or erosion type. wherein the erosion type is more of soft tissue involvement, and fragment type is basically associated with the bony component. So Hill-Sachs, just to define it, it's a compression fracture on the posterior aspect of the humeral head, which is dislocated anteriorly in front of the glenoid. So it's a defect in the humeral head. So H for Hill-Sachs and H for humeral head. So what happens with the Bankart lesion? This is just a picture to define the same. So when we examine the patient, the anterior capsulolabral structures are damaged here. You can see this is the glenoid, this is the humeral head, and this defect you are seeing here, that is the Hill-Sachs lesion. So basically, with the loss of anterior coverage, loss of anterior support, where this is the Bankart lesion, we see that the humeral head during extreme range of movements is the Hill-Sachs is prone to get engaged with the glenoid anteriorly. That is when the dislocation becomes prominent and the reduction can be difficult. So it can be true engaging. So after the fixation, so that dynamic examination has to be was done indeed ideally after the fixation of the Bankart lesion. So it's not before the fixation. When we do a Bankart repair, after that we examine for the patient whether it's getting engaged. Even after stabilizing the Bankart lesion, during extreme range of movements, if it's getting dislocated, it indicates that the defect in the humeral head is getting engaged with the glenoid. So that's called an engaging Hill-Sachs. So just a word on the Hill-Sachs lesion and the engaging lesions. With arm in abduction and external rotation, that is throwing action, the contact zone of the glenoid with the humeral head is called the glenoid track. A Hill-Sachs lesion which stays on the glenoid track cannot engage with the glenoid and cannot cause dislocation. A Hill-Sachs lesion which is out of the glenoid track has a risk of engagement and dislocation. So I just want to reiterate here that there is something called an on-track and off-track lesion. So the on-track lesions don't get dislocated, the off-track lesions go dislocated. So, and also the range of movement is very important. In what range of movement it gets dislocated is of utmost importance. In the mid range of movement, most on or off track lesions are stable. So what I mean by on track, off track is this defect what we are seeing, the Hill-Sachs lesion, that is in the track of the glenoid and it's not getting engaged with the edge of the glenoid. So it's in the track, whether it's on track, off track, in the mid range it's relatively stable. Whereas in end range, where in extreme abduction and external rotation, the off-track lesions are unstable. So here you can see the Hill-Sachs lesion is getting engaged with the glenoid here. So that is when it gets dislocated. This is the capsulolabral structure which is getting stretched. Even though it's repaired, it can get stretched and get off the glenoid. So this is called an engaging Hill-Sachs lesion. And with the glenoid intact, you are seeing that the glenoid is relatively intact here. When the glenoid is intact and the Hill-Sachs lesion is not engaging with the glenoid, this is relatively stable. And when the glenoid is fractured, you can see there is a glenoid is fractured here. That is when there is no support on the anterior side. The Hill-Sachs gets invariably, it gets engaged and gets totally out of track and dislocated. So this has to be read again. So I just request everyone to go and just have a look at on-track, off-track lesions, which is the next level of complication that can occur. Then the surgical options available for traumatic anterior dislocation. It can be seen as acute, chronic and recurrent. So acute irreducible dislocation, which is less than 3 weeks, we go ahead with the open reduction through anterior approach and internal fixation if there is any fracture. Then if there is a chronic dislocation which is more than 3 weeks, if the patient is functional, like it's months together and patient is managing and got adapted to the movements, then basically you can go ahead with skillful neglect and serial observation. If there is non-functional and then we go ahead with open reduction and capsulolabral repair with additional procedure depending on the anterior glenoid bone loss and Hill-Sachs. That's what I mentioned. Basically, we have to look for the anterior glenoid bone loss and the Hill-Sachs, especially when it's a chronic dislocation and recurrent dislocation. So in chronic dislocation, if the glenoid bone loss is less than 20%, we go ahead with something called Latarjet procedure. I'll just brief about it in the coming slides. If the defect is less than 25%, we go ahead with Latarjet procedure. If it's 25 to 40% Hill-Sachs lesion, we go ahead with allograft reconstruction or partial resurfacing. And more than 40% Hill-Sachs lesion, it's arthroplasty. So all the percentage of the bone loss are more specifically seen in CT scan rather than MRI. So the labral lesions are seen in MRI and the bony lesions are seen in the CT scan. That will help us decide the management. Now coming to the recurrent dislocation, the rehabilitation is the first line of management. We'll have to work with physiotherapy and rehabilitative exercises in recurrent dislocation, wherein some patients can really improve and they'll get adapted and know in what range of movement they'll get dislocation. They'll try to avoid those movements and eventually they are managed non-surgically. If there is no improvement with rehabilitation, then we'll have to evaluate and may need procedures for both glenoid and humeral head, depending on again the glenoid bone loss and Hill-Sachs lesion. So in recurrent dislocations, if it's less than 25% anterior glenoid loss, we go ahead with Bankart repair and Sach. I'll just speak on this in the slides. Then if more than 25% anterior glenoid loss, then we go ahead with Latarjet procedure. So Latarjet is done in acute as well as in recurrent cases, only that it depends on the amount of glenoid bone loss. Then if the lesion is further big, 25 to 40%, we go ahead with again allograft reconstruction, and more than 40% we go ahead with arthroplasty. So the most common set of patients presenting to us are in this range, less than 25 or 25 to 40, or in more than 25 with anterior glenoid loss. So the most common procedures we perform are Bankart repair with Sach, wherein the glenoid loss is less and the damage seen on the CT is relatively less, whereas it's a chronic dislocation, extremely active patient, and the glenoid bone loss is more than 25%, we go ahead with Latarjet procedure. So this is a table from Rockwood and Green. I've just picked it up here, volume 2, page 1564. I just want everyone to have a look at this eventually. It's a beautiful diagram, flow chart, wherein he describes about the management of acute, chronic and recurrent instability. And this may look very cluttered, but it's relatively easy when we just bifurcate and read all of this separately. So just to picturize the same, this is the Bankart repair, wherein we see the glenoid here, and this is the humeral head, and this is the part of the capsulolabral structure which is totally off the bone. So this is the Bankart lesion, and you can see the repair. So with the anchor sutures holding it, the capsulolabral structure is being brought back and being positioned here. So this is the Bankart repair. Along with that, we augment with something called Sach. So here what we do is, you can see that this is the Hill-Sachs lesion, this is the Bankart lesion. So the Hill-Sachs lesion is getting engaged. So once the reduction is done, the Bankart repair is done with the anchor sutures. At the same time, the capsulolabral structure here is being filled in the defect, that is a Hill-Sachs defect. So this will make it extra-articular and avoid engagement of the Hill-Sachs lesion. So this is called Sach. So Sach is always augmented with Bankart repair. Then there is Latarjet procedure. In the Latarjet procedure, it's arthroscopic as well as open, but the concept remains same, wherein a part of the glenoid, part of the coracoid process along with the conjoint tendon. This is the conjoint tendon. So conjoint tendon attached with the part of 2 centimeters of the coracoid bone is placed anteriorly in front of the anterior margin of the glenoid. So you can see 2 screws going in through the glenoid, and this graft is coracoid which is osteotomized is along with the conjoint tendon is being placed anteriorly, and the subscap basically behind this, the conjoint tendon acts like a hammock and prevents the anterior dislocation. So it is not just the bony part in the front which prevents the dislocation, it is also the conjoint tendon in front of the subscapularis which prevents the dislocation, acting like a hammock. So just adding a case that we did recently, we had a 30-year-old male who had recurrent dislocation since 4 years. He was a high demand active individual. He had a recent dislocation 2 weeks ago. The index dislocation was 4 years ago. Clinical evaluation, he was apprehension positive, relocation positive, and it was a classic recurrent anterior dislocation. So we went ahead with radiographs, MRI and CT scans, and we can see that in the MRI we are seeing the Hill-Sachs defect here when it is in position, and we are seeing that there is bony contusion here. So this was very chronic, and we went ahead with 3D CT images wherein we can see a small chunk of bone here. This is basically a bony Bankart. We can see here in this image here, as well as in the side images here. So it was a bony Bankart wherein there was glenoid bone loss anteriorly. We went ahead with Latarjet procedure because he was extremely active, young, and had a recurrence for 4 years, and there was a glenoid lesion more than 25%. So this is how we added 2 screws along with the coracoid graft, and he's doing fine as of now. So the take-home message here is the anterior dislocation of shoulder is very common clinical condition. Most can be managed by close reduction, and high chances of missing the posterior dislocation as high as 50%, and most of them go for chronic dislocations which are very difficult to manage and have to be open reduced and stabilized. Then there are recurrent dislocations which are very common in young males needing surgical management. So we have seen an array of surgical managements now. Then the surgical options are very specific and to be chosen wisely based on the clinico-radiological correlation. So clinical evaluation of the patient, the history, Evaluating the radiographs, the MRI and the CT, it should be a cumulative decision after discussion with the patient. Then the functionally adapted chronic dislocations and dislocations in habitual voluntary dislocators are cases for skillful neglect. So these are the set of patients which should not be touched and should be skillfully watched for the progression. And I have basically emphasized on anterior dislocation, the posterior dislocation and recurrent dislocation, the multidirectional instability are totally a different set of management and topics. So the moment I think of shoulder, I always feel I have learned that I still have a lot to learn in shoulder. Thank you.